So let's begin a little bit to the very, very basics of what traction is. These are concepts of things I'm going to say in these bullet points are some experiences that other doctors have had when they used the first pioneers of traction. So traction is basically a technique of stretching the spine to relieve muscle spasm and to separate joint surfaces. It's a technique. Here's the earliest type of traction as used by the pharaohs. Today in Sudan, they actually do bury people up to their waist, and they pull with some mechanism to stretch the part of the area of pain. Traction has been used at the very beginning of recorded history. Here's auto traction, a pre-Columbian stretching device representing auto traction. On the table that we manufacture, I'm incorporating a technique now, which is an overhead bar, and I have patients pull up on the bar as they're stretching. And you can actually feel the interspinous spaces open up more than if you just did the procedure alone. Of course, in this position they're horizontal. With the device that I use, we treat a lot of patients vertically, weight bearing. And one of the lessons of me speaking at this seminar today is, being here this week and taking courses, I have the wonderful benefit of many of the wonderful speakers that were here, the knowledge, and I'm listening to many of the speakers. And I think some of the principles that we're going to discuss, they're talking about, for instance, vertical positioning as opposed to horizontal positioning. Has some benefits as proprioception loading the spine as you're stretching and feeding up the cerebellum. Patients who get off on vertical traction devices, such as the M3D one, they notice an improvement in posture, a direct improvement in posture. They're standing straight because you're stretching the pain receptors, the motion receptors, and it's coordinating their muscles and creating tone as well as improved health. So as you're stretching by the self and you're pulling up, you can actually feel an increase in the space. Also, there's some benefits for treating vertical, but I wasn't the first one who thought of that. Here's Hippocrates, 450 BC. This was discovered in Italy, and this is an early horizontal traction table. For patients who don't pay their bill, this spike comes up. I got a kick out of this one because this is three-dimensional traction, isn't it? Believe it or not, from this picture, I'm going to add another innovation to my development. Because I kind of dig this vertical wrench. So you're not just being passively held, you're actually stretching the upper as well as the lower vertically. But Hippocrates used traction for scoliosis and kyphosis. So, yes, sir?
You would also, there's illustrations of using two poles. The men on each end would pole, and they would stretch the pole, and Hippocrates would walk on the spine.
Ah, that's great.
Illustrations.
There you go. Well, that's the thing with M3D. That's the thing with we're chiropractors. And you want to touch the patient when you're working on the patient, and you want to feel the separation. Like a flexion distraction table. That's a great device. It really helps. So M3D incorporates it into it. It's such a vital part of the protocols, of the M3D multi-directional protocols. But I think you have to make contact with the spine. Otherwise, what are we doing? We're just pretending patients are rubber bands and just stretching them and selling them a program of decompression, which we're going to talk about. This is a Turkish medieval traction device, and here's manipulation under traction, which you can do on the flexion distraction table, correct? That you have. You're doing manipulation, correct? And be careful when you go to the next restaurant. Just some bulleted points on what other physicians, because this is really earlier physician science, on what their thoughts are on traction. Gleason resurrected it for spinal deformities in 1666. Syriax, the father of medicine, orthopedic medicine, used manipulation and taught manipulation. He popularized the disc herniations. Skeptics at that point said it was of no use and of no benefit. He believes traction is constant. To be effective, needs to be constant to fatigue muscles. So later on, we're going to look at a study which described intermittent traction with no effect. In my own clinical practice, I do many things on each patient, and I'm flexible on my treatment approach. So if intermittent, cyclical pumping of the disc is not working, maybe long-axis sustained traction in 3 dimensions will work better. And I've seen that in practical application. Maybe vertical positioning is key for the patient. Maybe prone positioning is key. I'm going to discuss all that. I'm getting ahead of myself. How much weight do you put on the patient? Well, this gentleman, Jodovich, says 75 to 100 pounds is what you need. You can't get that with a manipulation alone. And it's difficult to get that on a flexion distraction table. You're flexing, you're applying force, but you can't generate that kind of force. So therefore, decompression tables are necessary. Traction tables that can deliver that force. Also, you want to quantify the force you're applying. Not just apply force manually and not know what it is, or an axial force. You want to have a digital readout. The modern conventional tables today have digital readouts on decompression tables. Christie was the first to publish a controlled study on the effectiveness of traction in acute and chronic back pain. His results, 30% improved, 10% worse. So some cases get worse. Yes, sir.
I thought acute is the only time you should do traction.
Say again?
I thought acute injury was contraindicated for traction.
I use one of the great features of the device that I use is that I don't take a severe patient like this and lay them down and spasm and start stretching them like a rubber band and stick a hook intermittent. I have them walk up to the table. You'll see the video. They hold on the bar with a comfortable underneath arms, and it's a gentle movement to begin to get the proprioceptor stimulated. It's stretched gently. It's not a sickle. I mean, you're controlling with your hands. Your hands are on the spine. Your hands should always be, most of the time, on the spine, unless you want just a pumping action. But the acute treatment for traction is wonderful. This is just this guy's comments. These are their observations.
So if there's a muscle tear and a strain, right?
A muscle tear and strain, yes.
Right. Then when you traction that, you're going to create more of a tear.
No.
No.
No, because you can go below threshold.
Well,
Gentle.
gentle.
Very gentle. In fact, one woman who I worked on had was referred to me by a chiropractor, and she could barely walk, sciatica, Facet syndrome, really acute. When she stood up on the Extentrac vertical platform, I pulled the key out of the foot support. So as they're stretching, the foot platform comes up. So it's extremely gentle. And of course, you don't produce any kind of decompression or traction. There's very little difference between the winter. I'm ahead of myself again. Unless you pay attention to lateral components. Is there a lateral component? What position is more important? That's why all of the literature we're going to see for a while shows many failures of traction not working, intermittent not working. There's no appreciation to the M3D, the multi-direction feature. In other words, us physicians, chiropractic physicians, have extreme training in musculoskeletal diagnosis and treatment. Why would one ever want to stretch somebody unless it's absolutely indicated in a linear position? I don't know. That's why Cox came in. Flexion distraction came in. Extentrac multi-direction came in. Because you want to appreciate, after an examination, the patient's symptoms. And then stretch them accordingly. is very, very interesting. This reminds me of the early subluxation degeneration posters that we're all familiar with. Traction should be only successful during the early stages of disc pathology, the 3 stages. Dehydration, loss of elasticity, rupture of the annulus fibrosis. Traction can be only effective in the first 2 stages of the disease. So the earliest you get the patient in, the better outcome. Some investigators find there's no correlation between duration of symptoms and treatment outcome. Celiacs, according to what you were saying, doctor, don't use it for acute lumbago. That's because he's correct in some ways. You don't take a patient like this, put him on a horizontal table, and begin to put a program in and stretch them. You're not even touching the patient. Maybe flexion distraction, but then you run the risk of opening up the posterior canal worse, and that patient may need flexion, extension, or lateral position, which you can do. Or sustained forces, so you're not pumping, not a pumping action. A lot of this treatment is like an adjustment. When you do manipulation, it's an art. Every chiropractor in this room can adjust my atlas probably as many different ways as you're sitting here. It's what way are you going to approach the subluxation? What is your angle of attack? Some do a Gosset, some do an HIO. Others do an occiput move. You have to, it's individualized treatment. Here's DeSiz and Livenu, who used traction in patients with lumbago and sciatica, with 71 to 68% results. Interesting fact, in their research, 93% showed improvement. The symptoms were less than 1 month's duration, but 60% a year or longer. So treat the patients early to get them. So when they come into your office and they have doing a history, if it's longer than, if it's real chronic, you may have a little bit longer duration, so you recommend longer treatment for the patient. It's not going to be 5 visits or 10 visits, it may be 20 visits. I've treated people for 50 visits if necessary. Got them well. Yes, Doctor.
Are there any studies with traction with manipulation simultaneously?
Any studies?
Like, yeah, where you do traction, while they're on traction, you're manipulating. Or an axial decompression, for example, if you go on an inversion device, after you do acute phase and then not acute, you hang them upside down after you adjusted them, you give them therapy, and you raise their head, they relax, and you whack, you decompress their entire spine. They'll feel a pop in their low back, and you just did surgery on them.
Here. Thank you very much. I really enjoyed having any questions.